Hey, I'm Jason Averilla, and we're going to be talking about some foot and ankle mobilizations and manipulations commonly used in the clinic. So we'll start with the first one, which is a taloacryl joint posterior glide. So I like to get this person to end range dorsiflexion using my hip, and I'm going to provide an anterior to posterior force, kind of on a slightly oblique axis due to that lateral malleolus being slightly posterior. So I'm going to support behind the ankle, or behind the tibia, and I'm going to take up that dorsiflexion, do a posterior glide. I typically will only do grade 4s and try to get to end range, since that is when most people feel a pinching pain in the front of their capsule. The next one this physician can do is a posterior fibular glide, so you can kind of hook the palm of your hand on their lateral malleolus and do that same posterior glide as you go through ankle dorsiflexion range of motion. Next one I'll show you is a eversion mobilization. So I'm going to use my right hand for her right foot, and I'm going to use the palm of my hand and kind of grip the calcaneus, and I'm just going to use my body weight in a hip shift to try to take her rear foot into eversion, which is going to help with pronation. You can also pair that with an opposite motion or inversion of the forefoot, so I can kind of wring out that joint. This is a little bit more gait specific. The next one I'll show you for eversion, since that subtalar joint is kind of on an oblique axis, about 20 degrees medial. We're going to try to do more of a translatory force. So I'm going to grab the calcaneus here, kind of toe out slightly, and I'm just going to provide a anterior to posterior force on that oblique axis. This one might not be as comfortable for the patient, so try to be as broad as you can so you're not just digging your pisiform into them. And that's another one to help with ankle eversion. Okay, the next one I'll show you is for the mid-tarsal joint. So we're going to try to gap this and create a manipulation or mobilization of the talonavicular joint. So for this one, you can do 2 different grips if your hands are big enough. You can kind of grab the top of the foot, and you're trying to open up that midfoot area, so a little cavitation. So you're just trying to open up that talonavicular joint. So I'm just grabbing and then spreading my hands apart. If you find that's harder, you have a patient with a bigger foot, you can do it more with one hand, and one hand on the bottom and one hand on the top, and internally rotate so the table is now blocking, and you're going to try to gap and open up that joint. So my direction of force is inferior, posterior, and medial. The next one I'm going to show you is just a MTP joint mobilization. So for this one, you're going to grab a hold of the metatarsal, the first metatarsal, and then I'm going to create distraction of the first MTP and then going through extension. So if your patient doesn't have that 65 degrees of extension range of motion, you can work on this. So you can work sagittal plane. If you're just going for general mobility, you can distract and then move the toes side to side, more frontal plane, or you can pull it and then twist for more of a transverse plane. Also to improve first ray extension is you can provide a top to bottom force. So I'm going to use my palm on this hand and push inferior and posterior on that first metatarsal to help facilitate first ray or MTP extension. All right, so for some manipulations you can do, so we'll start with the taloacryl joint distraction manipulation. So for this one, you're going to lock up their foot into dorsiflexion, eversion, and abduction. So some people will use a overlapping grip like that. That hurts my fingers, so I like to just kind of go one hand on top of the other. And I'm going to get them in that locked up position, and you do a quick thrust manipulation. Okay. If you want to do that same manipulation, you can go a couple inches lower to the mid-tarsal joint or the talonavicular joint, and you might be able to get a cavitation there also. So just a little bit lower on the joint, and then the same distraction force. Okay. Another one sometimes you can do for subtalar joint is you maximally invert the rear foot, and then just pronate the forefoot. And then this is my main mobilizing force pulling towards me. And we're trying to gap that subtalar joint. So we're going to that closed pack position of the subtalar joint, which is full inversion. Take up the slack and quick pull. And that's it.